This educational material is prepared and presented by Dr. Mohammed Alabnagi Mohammed.
Hello and welcome. Today, we are going to walk through the official Saudi Public Health Authority policy for the medical management of exposure to the rabies virus. This is absolutely essential stuff for any of us on the front lines dealing with these kinds of cases. So here's our game plan. We'll start with the basics, the policy framework, and some key definitions. Then we'll cover the critical first step, immediate wound management. After that, we'll dive into the risk assessment process, which is really the core of the policy. Next, we'll look at the specific post-exposure prophylaxis or PEP protocols. And we'll wrap up with the reporting requirements. Let's get right into it.
Okay, first up, Section 1. Before we get into the clinical steps, we need to understand the groundwork of this policy, what it's for, who it applies to, and the terms we'll be using.
So, what's the whole point of this policy? Well, it's designed to give us a clear, systematic way to assess the risk of rabies exposure and figure out exactly what preventative measures are needed. And you really need to take note of the scope here. This isn't just a guideline. It's a mandate that applies to every single healthcare facility and practitioner in Saudi Arabia, both public and private.
Now let's define our adversary, rabies, or al-Kalb. The policy defines it as a viral disease that attacks the central nervous system. But here's the line that should stick with you. It is fatal once clinical symptoms appear. There's no going back. This is why our response has to be perfect. And remember, the policy points out that a staggering 99% of human cases come from dog bites.
All right, let's talk about our tools. First up, vaccines. You know this, of course, but the policy defines them as antigens that get the body's own immune system to build up resistance. This is about teaching the body to defend itself. And then we have our second tool, which is very different, rabies immunoglobulin, or RIG. Think of this as bringing in the special forces. Instead of teaching the body to make its own defenses, RIG provides ready-made immunoglobulins that can start neutralizing the virus immediately. It's passive, direct immunity, and it's a game-changer in high-risk situations.
Okay, this next point is absolutely critical to your decision-making, the patient's immunization status. The policy draws a very clear line in the sand. Complete immunization means you have documentation showing at least 3 doses of rabies vaccine. Anything else, fewer than 3 doses, or if you just don't have the records, is considered incomplete. This distinction will dictate your entire treatment plan later on.
All right, on to Section 2. This is about what you do the second a patient with an animal bite comes through your door. These first few minutes are unbelievably important.
The policy could not be more clear on this. The first and most vital step is immediate, thorough, and deep washing of the wound. Don't skimp on this. Use simple soap and water. And here's the key. You have to continue washing for a minimum of 15 minutes. Set a timer. This one action can massively reduce the risk of transmission.
After you've cleaned the wound, there are a couple more rules to follow. First, try to avoid suturing the wound if at all possible. We don't want to trap any potential virus inside. And second, of course, don't forget the basics. Assess the patient for tetanus prophylaxis and administer antibiotics if they're clinically indicated.
Okay, now we're getting to the real heart of the policy. Section 3, Exposure Risk Assessment. This is where we stop and think, where we put the pieces together to figure out just how dangerous this situation is.
Step 1 of our assessment is to identify the animal. Table 1 here gives us a straightforward classification. High-risk animals are what you'd expect: dogs, foxes, wolves, bats, and of course any animal that's showing symptoms of rabies. Then you have medium risk for other mammals. And, an important one to note, rodents are classified as low or even no risk.
Step 2 is to classify the wound itself, using Table 2. It really comes down to whether the skin barrier has been broken. Category 1 is simple contact with intact skin. Category 2 is where the skin is broken a little, like a nibble or a minor scratch, but there's no bleeding. Category 3 is the most serious. This is any bite or scratch that goes through the skin, or any time saliva gets on mucous membranes like the eyes or mouth.
Now, before we put it all together, there's a crucial patient factor we have to consider. Are they immunocompromised? The policy is very specific here. We're talking about patients with conditions like active leukemia or those on immunosuppressive drugs like chemotherapy or high-dose steroids. Their management is going to be different.
And this is where it all clicks into place. You take the animal risk from Table 1 and the wound category from Table 2, and you find where they meet on this matrix, Table 3. It gives you a simple, color-coded risk level: green for low risk, orange for moderate, and red for high risk. That color is your guide for everything that comes next.
Which brings us directly to Section 4, the actual treatment. What post-exposure prophylaxis, or PEP, do we give based on that risk color?
So here it is. Table 4 is your definitive action plan. It puts everything we've talked about onto one page. You just find the patient's risk color from the matrix, check their immunization status, remember complete versus incomplete, and the table tells you exactly what to do. It could be no treatment, vaccine only, or the full vaccine and rig combo. It's all laid out for you.
Now let's really focus on the most important difference. For a high-risk red level exposure, if your patient is unimmunized, they get both rabies immunoglobulin and the full 4-dose vaccine series. But, and this is so important, if the patient has been previously immunized, they do not get RIG, they just need a 2-dose vaccine booster. Getting this distinction right is absolutely vital.
And just a few final crucial notes on how to administer PEP. First, remember that day 0 is the day you give the first vaccine dose, which might not be the same day as the bite. Second, you really need to get PEP started within 24 hours of the exposure. And finally, never underestimate the power of those first steps. The policy emphasizes that proper wound care combined with RIG provides the highest efficacy. The vaccine is essential, but it can't replace those initial actions.
All right, we've managed the patient clinically. Now let's talk about the final step in the process, which is just as important, the reporting requirements.
This is not optional. The policy is very clear. For any suspected or confirmed case of rabies, you are required to make an immediate telephonic notification and then follow up with a report through the HSN Plus electronic system. For all other animal bites, even if they're low risk, you need to submit a monthly aggregate report using the proper form to the official MOH email address. This educational material is prepared and presented by Dr. Mohammed El-Nagi Mohammed.
The reference for this explainer is Saudi Public Health Authority, 2024, Policy for Medical Management of Exposure to Rabies Virus, Riyadh, Saudi Public Health Authority.